You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is May 13, 2011, and I'm your host, Dr. Jay Portnoy. Our topic today, stinging insect allergy. Our presenter is Dr. Marc Serota. He's an allergy immunology fellow at Children's Mercy Hospitals and Clinics. Our first presentation is by Dr. Marc Serota. Dr. Serota is one of our first-year allergy fellows. He'll very shortly be a second-year allergy fellow. And he's going to update us on what's new with stinging insect allergy. So without any further delay, I will turn the podium over to Dr. Serota. Here's the mouse, and here's the keyboard. So take it away, Dr. Serota.
Okay, thanks, Dr. Portnoy. So I have no disclosures. The objectives for today, I'd like to review the characteristics of the common stinging insects. I'll review the classification and management of a patient with suspected stinging insect allergy, and to review the indications and administration of venom immunotherapy. So I have some pretest questions here. The first one is, allergy testing for Hymenoptera is recommended for all of the following except A, a 52-year-old woman who experiences total body hives alone following sting by a honeybee. B, a 7-year-old boy who experiences total body hives alone following sting by a yellow jacket. C, a 24-year-old woman who experiences anaphylactic shock, hypotension, and loss of consciousness following sting by a white-faced hornet. Or D, allergy testing is recommended for all of the above. Got that, or you want to?
Got it.
Okay. Number 2, the true statement regarding venom immunotherapy is A, traditional schedules are safer than rush schedules. B, rush schedules are as safe as traditional schedules as long as the patient is pre-medicated. C, it is allowable to mix any of the 5 Hymenoptera venoms into one vial. Or D, venom immunotherapy may continue during pregnancy, which is the true statement for venom immunotherapy.
There's only one?
Yeah.
Okay.
3, the true statement regarding Hymenoptera is A, wasps eviscerate themselves after they sting. B, African European hybrid bees have a more potent venom. C, it is acceptable to use whole body extracts for fire ant testing and immunotherapy. Or D, it is acceptable to use whole body extracts for vespid venom testing. Okay, so just some background before we get started with the specifics. Stinging insects belong to the order Hymenoptera, and the stinging apparatus is a modified ovipositor. Therefore, only the female insects can sting. So basically what happens in the hierarchy is a female will be designated as the queen, and her ovipositor is designated for egg production. And the remainder of the females become sterile, and their ovipositors turn into the stinging apparatus. So in the Hymenoptera group of insects, only the females sting, and it's because of that fact. So Hymenoptera that are important for allergy is broken down into 3 families, the Apidae, Vespidae, and Formicidae. And those are the ones that are most important for allergy and the ones that we'll focus on for today's talk. So the venom that we'll be talking about consists of a mixture of biologically active substances. There are 3 major components: enzymes like phospholipases and hyaluronidases, different types of peptides, and low molecular weight compounds like biogenic amines, acetylcholine, carbohydrates, lipids, and free amino acids. So these are the different types of Hymenoptera we'll be talking about today. The first is the Apidae, and within the Apidae you have the honeybee, the bumblebee, the sweat bee, the American common bumblebee or Megabombus, and Dialictus, which is a greenish type of bee. So just to go back, these are the 5 different types in the Apidae family. The 2 most important for our purposes are the honeybee and perhaps the bumblebee, but honeybee would be the most important in terms of allergy. So wild honeybees nest in natural hollows such as trees. Domestic honeybees have been bred for pollination in agriculture and for honey and wax production. So they're more docile and less likely to sting or swarm unless provoked, as opposed to the natural honeybees found in nature. And the sting apparatus is barbed and breaks away from the insect body and remains in the skin, which is called sting autonomy, and that causes evisceration of the insect and death. So it can, the stinger can basically go in, and then because the barbs are there, if you try and pull them back out, it's kind of like a one-way valve, and it eviscerates itself when it tries to pull out. So it essentially sacrifices itself for the colony when it stings something. So African-European hybrid bees, also known as killer bees, escaped into the wilds of Brazil and migrated through Central America and the southern U.S. They're essentially hybridized to kind of take the African nature of bees, which would be that they're harder working, more aggressive, and merge them with the European bees for the purposes of honey and wax production. But they actually escaped their normal confines and now kind of ran wild and migrated. So their appearance and their venom are the same as the bees that were used to hybridize them, but they're just more aggressive, and that's why they were called killer bees. So, originally I kind of thought in my mind that they were somehow more potent and more toxic, but actually the toxic reactions occur to humans or livestock as a result of the high number of stings because of their aggressive nature and not the potency of their venom. Bumblebees are generally not aggressive and usually do not sting unless seriously provoked. There's limited cross-reactivity with the honeybee sting reaction. So just because you're allergic to honeybee doesn't mean you'll be allergic to bumblebee sting. And sweat bees have very few reports of allergic reactions, and the allergy is unrelated to honeybee allergy. It's not something that we commonly encounter within an allergy practice, but it is known to exist. So the next group is the Vespidae. This makes up yellow jackets, yellow hornets, and white-faced hornets, and we have some pretty disturbing pictures of each one on the right.
I think they're very pretty.
They're beautiful and yet scary. And then lastly, the paper wasps. So these four are the major ones in terms of allergens that you're going to encounter in terms of allergic reactions. The paper wasp, to me, is particularly menacing. So within the Vespidae, in general, they use a wood pulp to construct nests that contain one or more layers of comb, each containing a large number of cells. And these comb layers are attached in a vertical arrangement and usually are enclosed in paper mache outer layers. Again, in general, new queens mate, survive the winter, and initiate new nests the following spring. And the other members of the hive, including the existing queen, die in the fall. So they basically have this life cycle. The sting apparatus has finer barbs than the Apidae and does not usually autonomize. So in general, you can think of them as not doing that, but some of them do. Some yellow jacket species, for example, still can. And there are barbs there. They do exist, so it's theoretically possible they can have the same sort of phenomenon, but it's just not nearly as common. And for board purposes, if you had to choose, the honeybees are really the classic ones that do this.
Yeah, but just because the stinger comes off doesn't prove that it's a honeybee, does it?
Mm-hmm. So just to go into some more specifics about each type of vespid, yellow jackets are scavengers. So they like picnics, orchids, trash cans, dumpsters. They are highly aggressive and sting for no apparent reason. And they're particularly aggressive in the autumn when large populations are competing for limited food. Remember that life cycle happens, so when they're starting to die off, they become even more aggressive. And nests are located in the ground or in cracks in buildings, gardens, residential landscape materials. The main point here is honeybees tend to nest in the trees, whereas yellow jackets and other vespids tend to not be as high up there, and in the case of the yellow jacket, they're actually in the ground. So when a patient comes in and gives you the history, one of the things that may be important to note is where the nest was. If it was located in the ground or something like that, it's more likely to have been a yellow jacket. If it was clearly a honeybee nest in a tree or something, it's more likely to be that. So a good point of history. Yellow hornets and white-faced hornets are aerial nesting. So basically they're similar to yellow jackets, except instead of nesting in the ground and those types of places, they're basically aerial nesting yellow jackets. So they're different in terms of their appearance and all that, but they're also different in terms of where they nest. They're present in North America, but not Europe, and they build nests in shrubs and trees. Their defensive nature is provoked by vibration, and they're also very aggressive. So if you shake a tree with with the yellow jacket nest, nothing good. I mean, yellow hornet or white-faced hornet nest, nothing good's going to happen. And then lastly, paper wasps. They build a nest similar to the other vespids, but it's limited to a single layer of open cells with minimal outer covering, and that's kind of where the name came from. It basically looks like paper mache. They have that characteristic slender waist, so they have the large stinger apparatus in the back and then a large face and forebody, but the middle is this little tiny slender waist. They're found on windowsills of homes, eaves of houses or barns, and railings of wood decks. You've probably seen one in your life. They're also scavengers, so similar type of places where you would find the other scavengers, picnics, garbage cans, dumpsters, things like that. They're less aggressive than yellow jackets or hornets, but they tend to sting repeatedly and without losing their apparatus. So they're the least likely to have that phenomenon where they sting and they get eviscerated. So they tend to sting repeatedly.
What did you say that hornets in case?
So the hornets are in the ground, and then
Hornets are in the ground.
I'm sorry, I said that badly. The yellow hornets and the hornets are in the air. Yellow jackets are in the ground. Yeah.
The yellow jacket, I think, can make like a wasp sort of look at that too, right?
Mm-hmm. I think it starts out that way, and then they add a little bit more layers than the wasp does. The wasp keeps it like super simple, but I think it can be somewhat variable too. So then lastly of the three groups is the Formicidae, and these are basically the ant group. The first one there is the most common in terms of allergy, the Solenopsis invicta, which is the fire ant. But you also have the jack jumper ant and the harvester ant. There's pictures there. But the fire ant, again, is one that's most commonly associated with allergic reactions, particularly in the southern parts of the U.S. So ants of this family have a true stinging apparatus, which separates itself from other ants which don't actually have a true stinging apparatus. When they bite, they anchor by their mandibles and pivot to administer multiple stings. They build nests in mounds of fresh soil that can be 1 to 2 feet in diameter and elevated at least several inches. They're very aggressive, particularly if nests are disturbed. So if you walk through or fall on an ant nest, I've never done this, but I would imagine it's not a fun experience. They're located in the southern U.S., and as much as 50% of the population is stung each year by fire ants. That's pretty impressive. They are unique in that they have a poison sac containing piperidine alkaloids, and that's something that I've seen in board questions. So for whatever reason, they like that fact. Nests of fire ants are actually found as north as Maryland, so that suggests that they are capable of adapting to cooler climates and are capable of migrating to cooler climates more north. But in general, they're thought of as being a southern U.S. problem. Multiple ants administer multiple stings, and they sting in a circular pattern, creating lesions that are called sterile pseudopustules. So basically, they look like little pustules that aren't actually infectious. They're sterile, but they can become secondarily infected if excoriated. So that's an example of sterile pseudopustules. I don't know if it's terribly easy. I think the one that's closest to more of the bicep area, you can see the little pustules popping up, and those are actually sterile, but I could see where a physician would mistake that for more of an infectious process.
Or bed bugs or something else, too.
Mm-hmm. Also, just as an aside, when I was looking through some of these things with fire ants and Middletons, for some reason, it actually says that their stings are painless. I don't know if that was a typo or whatever, but I asked Rodney from the South, and I asked him, he said that is absolutely not true.
I asked one last weekend.
I've never had the pleasure of being stung, but...
I guess every...
Do you have the suitor punch?
Yeah.
You still have one?
No, it's gone.
It's gone.
Camouflage. Huh? Camouflage. And as many times I've been stung, I've been dead.
So they are definitively painful. So the classification of reactions when it comes to different types of stings, they're classified as either local or systemic reactions and can have an immediate or delayed time course. So local reactions are limited to the area contiguous with the sting. Large local reactions represent a late-phase IgE-dependent reaction that is mild initially but develops after 12 to 24 hours to a diameter that often exceeds 20 centimeters and sometimes involving the entire limb. So although it sounds somewhat severe, it's still considered a local reaction if it's contiguous with the area that was stung. Release of inflammatory mediators may result in lymphangitic streaking towards the axilla or inguinal regions. Again, this is not an infection, but something that I would think if I saw in practice, I would be tempted to think that there was some infection going on there as well. Local reactions subside on their own after 5 to 10 days, and there's no serious risk except anatomic compression, particularly if you're stung in the head or neck region. You can have anatomic compression of those areas, but local reactions wouldn't pose a life-threatening or serious risk to the patient, with that one exception. On the other hand, systemic reactions involve one or more anatomic systems distant from the site of the sting. It's IgE-mediated and can cause anaphylaxis. Can present as an acute reaction with only cardiovascular signs, which can delay the diagnosis, which is pretty concerning, especially if the person isn't immediately aware that they were stung. They can present as the first signs or symptoms as cardiovascular, and you may not know exactly what's going on because they may not come telling you that they were stung by something because they may not have realized. So in a study of 2,602 stinging insect allergic patients, 16% reported only cutaneous symptoms, 24% had life-threatening reactions, where 15% of those actually lost consciousness, and 44% had what was described as moderate reactions, which was kind of in between the two. There's a poorly understood phenomenon where venom-allergic patients can develop cold urticaria from weeks to months after a sting. So they're stung, and then weeks to months later, they can still have cold-induced urticaria. No one's sure exactly what the mechanism of action of that is, but it's something that's been described. It's probably something that's tested. So
Just at the site? Or?
No, it can be diffusely anywhere, and that can last for months after the actual sting. So if someone actually has cold urticaria, it's probably worthwhile to ask them, have you ever been stung by stinging insect, and what was your reaction? Because some of these people may have a history of that. Interesting.
I didn't know that.
Systemic reactions can be caused by toxic effects from the vasoactive substances in a large number of stings. So not necessarily a true allergy in the sense that's not IgE mediated. It's actually related to the vasoactive peptides and other substances within the venom itself. Especially depending on the number of stings. If you had a high number of stings and you have a high number of vasoactive substances all entering your bloodstream at one time, you could have anaphylactic-like symptoms from that without actually having true IgE-mediated allergy. Massive envenomation can also cause renal failure, rhabdomyolysis, hemolysis, ARDS, or DIC. Again, related to the substances in the venoms, not necessarily from an IgE mechanism. Seizures can occur after multiple fire ant stings. That's also been described in the literature, and it's probably board-worthy. Unusual and poorly understood reactions include serum sickness-like reactions, encephalitis, peripheral and cranial neuropathies, glomerulonephritis, myocarditis, Guillain-Barré syndrome. No one had a 100% good explanation for why these things would occur after stinging insects, but to me it kind of looks more like a autoimmune type phenomenons where there may be some cross-reactivity or some precipitating out of immune complexes, something like that.
Yeah, it wouldn't be surprising to get an immune complex after getting a whole bunch of this foreign stuff injected into your system. 2 weeks ago, I saw a patient who came in with a history of being stung multiple times, and then about a week later developed urticaria, this vasculitic urticaria type of thing, and then arthralgias and fever and a classical serum sickness type of pattern. So it does happen.
Were they stung with fire ant or?
No, they were stung by bees. They
Do we have fire
thought it
ants
was
in
bees.
We don't really have fire ants in Missouri, do we?
We generally will, because of climate change, everything is moving north.
Killer bees are picking up those fire.
So diagnosis-wise, in terms of a patient who has suspected stinging insect allergy, I put there at the top history plus allergy testing. It's kind of the gold standard for any of our things. It's not one or the other. It should be a combination of both. Venom-specific IgE antibodies are present in a large number of clinically non-reactive people. So just because you have high specific IgE antibodies to them doesn't necessarily mean that clinically you would have allergy if you were actually exposed to the sting challenge, especially if you didn't have any history previously of a stinging insect reaction. So physicians should inquire, and this is something I didn't really think about myself either. Physicians should specifically inquire about reactions to stinging insects as part of the routine history, because most individuals fail to mention the event. If you just take part of your past medical kind of normal history, and most people won't tell you I was stung by a bee and had my throat closed, but if you actually specifically ask them, they'll tell you about that. And that's something I didn't really do as much of initially in my training that we probably should do a better job of, or at least I should. Patient identification of the insect is not reliable. So if a patient says that they were stung by a honeybee or a wasp or yellow jacket, that's not reliable in terms of that being the actual insect that the patient was stung by. It's been shown. Location, timing of the sting, or the location of the nest may suggest the type of insect like we talked about. And the number of stings and location on the body will help differentiate local from systemic reactions. And also, I just put in terms of diagnosis, be aware of effects of treatment medications. Epi and antihistamines obviously are going to affect the course of how they responded to the sting versus not having those medicines. And also effects of daily medications like beta blockers also could have played a role in terms of the severity of the reaction or how they presented. So testing-wise, when someone comes in and you suspect a stinging insect allergy, you would do intradermal technique using the 5 Hymenoptera venom protein extracts. So honeybee, yellow jacket, yellow hornet, white-faced hornet, and paper wasp. Whole body extracts contain little or no venom and are not useful. The one exception to this is fire ant sensitivity can be tested with reasonable diagnostic sensitivity and specificity using whole body extracts. And fire ant venom extract is actually superior for testing and for immunotherapy, but it's not widely commercially available. So people are actually getting the fire ant venom itself, but it's just not widely available, and it's acceptable to use the whole body extracts for fire ants, but it's not acceptable to use those for any of the Hymenoptera venoms because they simply don't have a high enough concentration of venom, and we have good alternatives. So when it comes to the actual testing, like I said, you test for all 5 Hymenoptera. You start typically with the skin prick test at a concentration of 1 microgram per ml, and then if they're positive, you stop there. If they're negative, then you proceed to the intradermal testing. You can see the concentrations there starting at 0.001 and going up to the full concentration that you did the skin prick to. At any point you get a positive, you're done there. If you continue to get negatives, you can go all the way up. Sensitizations may have occurred to multiple venoms after a reaction to a single insect. So while there's not full cross-reactivity, if you're stung by one stinging insect, you're more likely to have a reaction to another type. That's why you have to test for all 5, even if they've only had a reaction to honeybee. That's kind of different thinking than we think of like for food allergy, where you're very specific. With stinging insect allergy, you want to cover all 5 of the common ones because there can be some cross-reactivity.
What about with fire ant cross-reactivity?
I didn't see anything about fire ant. Was kind of its own separate entity. So there's really no cross-reactivity with that.
Has anybody looked at the intradermal testing that maybe minimize the number of times you have to stick somebody for each of these antigens? I mean, is the risk that high that you have to do it through the 4?
You could probably start with the 0.01 rather than the 0.001.
Yeah. I'm just thinking if you're looking at any of your pediatric patients, they're like, that's fun. Yeah.
The times I've seen it, we did all 5, but I think if you skin prick and you're negative, it would make me feel comfortable enough where you could probably start with a higher concentration than intradermal, but
I'd probably start with the 0.01.
But I mean, this is the way that it's been done.
Yeah, I follow
I mean,
protocol, just blind,
I mean, I'm sure you could. I'm sure you could do a study and show that. I'm not aware of a study that's been done, but I'm sure it's probably likely. Okay, so like I said, you want to test for all 5 because there can be cross-reactivity. So with regard to testing, some patients have negative skin tests due to a refractory period in the days or weeks after a sting. So these patients should be repeated after 4 to 6 weeks. So if you have a good history, a patient comes in with stung, clearly had a reaction that warranted testing, which we'll talk about what those are, and you test them and they're negative, it could be due to this refractory period, and you'd want to repeat the testing in 4 to 6 weeks because especially if their history was good, you're still pretty concerned that they could be allergic. Negative skin tests in a history-positive patient may represent a non-IgE-mediated reaction, like I said, from either the vasoactive substances, toxins themselves, and could also be from a subclinical mastocytosis, which is also reported that people who have subclinical mastocytosis when they have a stinging insect response, that could be an indication that they have that. So that's also been described, and it's probably also something that's tested on the boards. If the skin testing is negative and the history is convincing, specific IgE should be sent, which is positive in 10% of patients with negative skin tests. So this is one of those situations where you would want to send specific IgE if your skin test was negative but your history was convincing, which isn't something we would do with necessarily other types of allergies. And if the blood testing is also negative, then skin test should be repeated, like I said, once you're out of the range of that refractory period. High specific IgE is usually diagnostic, but low levels do not rule out allergy. So if you have a high specific IgE, you feel pretty comfortable, has a high positive predictive value, you feel pretty comfortable saying the person's allergic, but low levels don't necessarily rule out allergy, so you can't say they're not allergic if their levels are negative. One other thing I saw discussed was positive testing in a patient that has never been stung is kind of a clinical dilemma. Sometimes patients come in requesting all sorts of things, and doctors will send the test because the patient requested it, but they never actually had any clinical history of being stung. There's a 15 to 20% chance that a person with a positive test and no history of being stung will have a systemic reaction on sting challenge. So given that risk, some clinicians consider immunotherapy in that scenario. It's kind of hard to decide what to do. You kind of have to weigh the risk and benefit of starting immunotherapy versus the person's chance of actually having an allergy or being stung.
So in other words, you get like a food inhalant and, panel that's sent to you from a new patient. What do you do?
Yeah, what do you do? I mean, I was going to kind of ask the group what you do.
Well, fortunately, stinging insect usually isn't ordered along with
it usually isn't.
different profiles, so we don't run into that very often.
Yeah,
But every once in a while, Uncle Jimmy had a terrible reaction, and I want to know what the police risk is. And so somebody runs the test, and then you're stuck with trying to figure out what to do with it.
Yeah.
So I've had that twice.
So fire ant testing, like I said, is done with whole body extract. Venom's available for more laboratory, for research purposes. It's considered positive with skin prick if the test is positive at a concentration of 1 to 100 weight per volume or less, so that would be the minimum, or 1 to 1,000 by using intradermal method. So if those or any more dilute concentrations are positive, those are considered a positive test. So a little more about diagnostic testing. Some people do sting challenge testing, which is the gold standard in research studies. Sting challenge in untreated patients has a systemic reaction rate of 21 to 73%, and this wide range likely represents differences in the insect and how much venom a given insect happens to inject, which is very variable among the vespids. So vespid, when they inject, they tend to have a very variable concentration of venom, whereas honeybee venom tends to be much more reproducible. They tend to give a much more constant amount. The vespids actually vary widely, and that's probably why there's such a wide range in that systemic reaction rate. Sting challenges aren't used routinely clinically due to obviously safety concerns. It's much more of a research study kind of thing. And the lack of a reaction to a single challenge sting has been shown to be of limited clinical significance because the subsequent sting can still cause systemic reactions. So in research studies, they usually wouldn't do just one, they would do multiple. But in terms of clinically diagnosing somebody, because of these facts, it's just generally not useful to do that. And if you combine the history with the skin testing and blood testing, you usually can get just as good a result. So preventing an acute reaction, number one, like for all allergies, is avoid high-risk exposures. So things like yard work, garden work, avoiding trash containers, avoiding exposed food and drink. Insect repellents are of little or no benefit, and avoiding bright colors is of uncertain benefit. So the things I looked at, they really couldn't find very good evidence to suggest that these things work very well. It's much more useful to avoid high-risk exposures and have immunotherapy if you know you're allergic than it is to do some of these other things that are kind of in the common mindset. I remember I played soccer growing up, and no team ever wanted to be yellow because that was like everyone thought it was associated with attracting bees, but
they're actually much more likely to be attracted to ultraviolet colors, which we wouldn't see.
So regarding venom immunotherapy, it's the treatment of choice for preventing systemic allergic reactions to insect stings. It's designed to include only patients with a history of previous systemic allergic reaction to a sting and evidence of allergy on skin or specific IgE testing. And some actually argue for local reactions as well. So we think of it more as for systemic reactions, but if someone is in a particular line of work where they are getting stung repeatedly and having repeated large local reactions and it's bothering them, immunotherapy actually does work in decreasing the magnitude of these large local reactions. So you can still do it for that based on the clinical scenario, but it's not generally recommended. So the risk for systemic reactions with a future sting, If you've had recent severe anaphylaxis, that number is 40 to 70%. If you've had large local reactions, it's less than 10%. And children with reactions limited to cutaneous signs is less than 10%. And by that I mean you can have total body hives as a child, so something that would be considered systemic in the fact that it's not contiguous with where they were stung. But if it's only cutaneous signs, children, and by children I mean less than 16 years old, still have a low risk of having anaphylaxis on a future sting. However, the next point there, in adults that are 16 or greater, there are cases of cutaneous-only reactions that progress to life-threatening anaphylaxis with subsequent stings. So this is where the recommendations differ a little bit. If you're less than 16 and you have total body hives, you don't need to do immunotherapy or do testing. If they've had total body hives and they're 16 or greater, they do have an increased risk of having systemic reactions on repeat stings, and you would want to test them and would want to treat them with immunotherapy if their testing suggested that.
Is that number 16 arbitrary or based on the study?
It was based on a study. Yeah, it was based on a study. So the efficacy of venom immunotherapy is essentially incredibly efficacious. The standard maintenance dose is 100 micrograms for each individual venom. Poor responders may need to go up higher, up to 150 micrograms. Most people have very good response with 100 micrograms. So the 300 microgram maintenance dose of the mixed vespid venom, the reason it's 300 is because there's 100 of each of those three, is 95 to 100% in preventing systemic reactions. If you drop that down to 100 microgram maintenance dose, which would basically be like around 33 micrograms of each of those, you get 75 to 95% in preventing systemic reactions. So some people may choose to use the lower dose because of side effects or something from the immunotherapy, but it seems to me that if you're going to do immunotherapy and you have a dose that's essentially almost 100% effective, that's the one you probably want to use. Even in cases of treatment failures, so that subsequent sting challenges resulted in reactions, they were still more mild compared to pre-treatment reactions. So even in the rare case of a treatment failure in that 5% or so, you're still going to reduce the likelihood of them having a severe or life-threatening reaction, even if they didn't completely become, not responsive to the sting. So the choice of venom extract, therapy should include all venoms that are positive on testing, not just the thing that they may have had the reaction to. The most common therapy is the mixed vespid venom preparation, which is equal parts yellow jacket, yellow hornet, and white-faced hornet venoms. Yellow jacket alone is actually cross-reactive to protect against the others, but therapy with any single venom gives 15 to 20% less immune response and less reliable clinical protection than the mixed vespid venom. So essentially they seem to have a synergistic effect. So if you use the mixed vespid, they tend to work synergistically, so it gives you a better protection against any one of those than you would just by using a single vespid alone.
So if you're just allergic to, if you're just positive to yellow jacket, then you still use all three?
Yeah.
Like the mixed vespid.
So any of those, you use all three.
Mm-hmm. So skin testing for the paper wasp is also positive in 50% of vespid allergic patients, another good reason to make sure you're testing for all 5. Treatment is usually given in a separate injection because there's a potential for proteolytic effects of the enzyme allergens. So you can do all 3 of those vespids mixed together, but the recommendation is not to mix the wasp venom with that because it could lyse the enzyme allergens. Or the enzyme allergens could lyse the other, the allergen. The standard recommended dose of 100 micrograms for each venom was originally selected to be equivalent to the protein content of 2 to 4 stings, and that seems to be based off the honeybee, which is a fairly consistent 50 microgram per sting. So if you give someone 100 micrograms, you're basically giving them the equivalent of 2 honeybee stings. But like I said, the vespids are actually much more variable, and each sting could be anywhere from 2 to 20 micrograms per sting. So basically, when you're giving someone 100 micrograms of the vespids, you're giving them actually, could be anywhere from, 5 to 50 stings equivalent. So 100 microgram continues to be the standard dose because of the excellent experience with efficacy. But lower doses are efficacious, but with a higher likelihood of treatment failure, like we saw that 75 to 95%. I would imagine that's probably more true in the honeybee, since the honeybee sting seems to have a higher concentration, a much more standardized concentration per sting, whereas the vespids, because they're lower, you probably could get away with using lower doses, but because of the good experience with the dosing, that's tended to be the convention. It's the same dose for all ages greater than 3 years old, and higher doses are beneficial for treatment failures, like we talked about. So regarding the schedules of immunotherapy, they vary according to the recommendations of the source laboratory, which has prepared the allergen extract, and the preference of the physician. The adverse reaction rates are similar to aeroallergen immunotherapy. With modified rush or rush schedules without any pretreatment, adverse reaction rates tend to not be increased. So whereas with aeroallergens, if you do a rush protocol, you want to pretreat them with steroids and antihistamines. With rush protocols with venom immunotherapy, it's actually as safe as aeroallergen. And actually, in some studies, as part of my rush articles I was writing, in some studies, reaction rates are actually decreased in rush regimens. And so patients who didn't tolerate a standard traditional buildup because of side effects actually did tolerate a rush protocol. And the thought was it was because they were actually getting a lower total cumulative dose of the venom. So if someone actually goes on a traditional buildup and fails that for venom, they actually may very well tolerate a rush buildup because you're giving them a lower total cumulative dose.
Actually, Dave Goldman, when I spoke with him, said that the risk of reacting was actually lower with the rush, in part because you're getting a fewer number of injections, because the risk per injection is constant. So if you get fewer injections, you're just lowering the risk.
I think you were telling me too, Dr. Portner was telling me that if someone has positive skin reactions, you'll even initiate therapy, soon after. There's no need to do anything.
Yeah, if somebody has a positive skin test and we want to give them venom immunotherapy, we start giving it to them that day. Why not? Why send them home and have them be at risk of a sting reaction?
Just complete the rush protocol that day. Yeah.
Just do it right there while they're in the clinic.
I might have missed this or not, but what did you say the build-up regimen was like?
Well, it's different for different people, but you can do a rush schedule, you can do a modified rush, or you can do traditional. Most people,
Cluster.
Yeah, a cluster. I would tend to do rush since it's been shown that it's really no more dangerous than doing or maybe even be less dangerous than
2 hour rush.
Yeah,
Is it
rush all the way
comparable?
to maintenance.
I mean, like, is it comparable, like, to, standard pollen?
Well, you'd rush into maintenance.
Right, but I mean, like,
pollen where you'd stop, like, at the end of the yellow vial, let's say.
okay. So, I mean, it's broken down to, like, different concentrations, different vials.
Yes.
All divided, similar to the, okay.
Yes, yes.
So I didn't include that in there, but yeah, it's pretty similar concentration-wise. You're just going to probably want to rush them.
Different, yeah.
You get a package insert, and the product has some pretty good
Package
directions.
insert doesn't talk about rush.
There is the one, because I got a patient on it, that talks about the initial cluster that you do, and then there's kind of like a weekly injection for so many weeks, and then you spread it out after that. So.
Right, but the rush schedules are not FDA approved, so they're not in the package insert.
So once you hit maintenance, you could slowly increase them to space out every 4 weeks, which you want to keep them on for at least a year. And then over a period of years, there's good clinical experience to increase the interval to 6 to 8 weeks. So basically, you're going to start out weekly, increase it to 4 weeks, and then you can increase it even to 6 to 8 weeks. There's no recommendation to increase it further than 8 weeks. And then from the practice parameter, you want to continue for 3 to 5 years. Relapse is less likely with 5 years of treatment than with 3 years. So especially in patients where you have severe anaphylactic reactions or high likelihood of future stings, it may be something to consider keeping them on for the full 5 years as opposed to trying to stop at 3 years. It's kind of a little bit clinical judgment, but we do know that if you keep them on for 5 years, they're less likely to relapse. There's no specific test to determine which patient will relapse. Positive skin test after therapy does not predict systemic reactions. 80 to 90% of people with positive skin reactions don't have a reaction when they're actually stung after immunotherapy. So you can't use positive skin tests to say that that person is at increased risk. Or you may say, I want to skin test them before I stop immunotherapy. It just doesn't work like that. You're not going to know. Patients with a history of severe reactions may still be at risk after 5 years. Some experts recommend indefinite treatment. So if you had a very severe life-threatening anaphylactic reaction, and maybe there's a clinical picture where there's a high likelihood of sting, or the person has severe anxiety related to future sting, some people might say in that scenario to keep them on longer than 5 years. From the evidence I've seen, 5 years works really, really well, and most likely they're not going to have a reaction, but in certain clinical scenarios it's something that you may want to consider. And the package insert from the manufacturer actually recommends lifelong treatment once that's changed. I don't know if you've seen the package insert recently, but they actually recommend lifelong treatment. So, but that's not what the evidence suggests. It's not what the practice parameter says. But in certain rare scenarios, you may want to consider that. So some additional important concepts. Some of these may be board-worthy. Venom allergy can be fatal even on the first reaction. Like sometimes we think of allergy usually as needing to be sensitized, and then you have the severe reaction on the subsequent exposure. But with venom allergy, even on the first reaction, it can be fatal. Adults, after systemic reaction, 30 to 60% will have another systemic reaction on subsequent sting without venom immunotherapy. With venom immunotherapy, if it's done properly for the proper amount of time, it's 5% or lower. So it works extremely well. Children, after systemic reaction, 30% will have another one without venom immunotherapy, and probably around the same after treatment. Honeybee stings can cause higher rates of recurrent systemic reactions compared to vespids. I found that interesting because I would think of vespids like hornets and wasps as being like, for some reason, more potent or more dangerous or more something. But actually, honeybee stings are actually the ones that cause higher rates of recurrent systemic reactions. And that may be, again, because they have a more consistent venom than the vespid. You know, one time you might get stung with a vespid and have 20 micrograms, then you get stung again and you only get 2. So maybe you're less likely to have a reaction, whereas honeybee is so constant that if you're allergic and you're going to get the dose. Honeybee venom immunotherapy is also less effective in preventing future systemic reactions than vespid, 77% versus 91%, and it's also not as long-lasting, so you're maybe more likely to consider lifelong treatment, again, in that scenario where someone has those factors that would make you consider that. If they're allergic to honeybee, you might be more likely to do that than if it was a vespid allergy. So what about venom immunotherapy in pregnancy? One study had 15 women that had a total of 22 pregnancies. 19 were normal infants. 1 had a first trimester miscarriage. 1 had a miscarriage due to placenta previa. And 1 child had multiple congenital abnormalities of an unknown cause. This was a small study, but it's in line with what is expected for the general population. So it was thought that none of these events were specifically related to venom immunotherapy. The recommendation is don't initiate venom immunotherapy during pregnancy, but you may continue treatment. If they're already on it and they get pregnant, you don't have to stop the treatment for that. Again, this was a small study, but the findings were pretty in line with what you would expect just if you tested any 22 pregnant women. What about venom immunotherapy for large locals? It does reduce the severity and duration of recurrent large locals by about 50%. You're not at increased risk for systemic reactions when it comes to large locals, but you may want to consider it for people who get frequent exposures or are very bothered by large locals. So you kind of have to weigh the risk and inconvenience of venom immunotherapy versus the benefit of preventing large locals. It's kind of a clinical decision between the patient and the physician. Venom immunotherapy, if the patient has a good history but all testing is negative. So what do you do if the patient has a really good history? They were stung by a honeybee, had a very obvious history that you felt was an allergy, but then the testing is negative. That's another kind of clinical dilemma, kind of the opposite of what we talked about earlier. So these are kind of my thoughts. Consider patient-specific factors. Was there a reliable history? What allergens do you include in the therapy? Because you want to cover the things that they may have been allergic to. And remember, their history is not reliable. So if they say I was stung by a honeybee, and you say, okay, the testing is negative, but they clearly had a reaction to this. Well, maybe it was really not a honeybee. Maybe it was something else, and you're not even giving them the right venoms. So you want to take into consideration the likelihood of further exposure, access to medical care. Are they reliable with an EpiPen? The severity of the previous reaction, and then patient-specific factors like cardiovascular disease, if they're on a beta blocker, things like that. Some clinicians say in the literature they would favor immunotherapy if the history is clearly positive, since venom immunotherapy is relatively safe and very efficacious. But I would question doing that because you don't even know what you should put in there, for their venom immunotherapy. So even if they have a really, really good history, it's clear you can even see that where they were stung. It's like if their testing is completely negative, what do you do? So I would suggest you do the specific IgEs. If those are negative, you repeat the testing in 3 to 6 months. If that's negative, then you kind of have to scratch your head and say, what else is going on here? So, but I have seen some people write in editorials and other things that they would still consider doing it because it's so efficacious and safe.
So what would you put in the other
Right.
I don't know.
Right.
Free shots, right?
Right, exactly. So, yeah.
Heavy fire in it.
Yeah. But it's another one of those dilemmas. So venom immunotherapy for systemic reactions involving only the skin or angioedema. Again, adults, yes, there's an increased risk of systemic reaction of future sting. Children less than 16, no, there's no increased risk of systemic reaction. What about checkotriptase? Some experts, I think Dr. Portnoy was talking to us about Dr. Golden, who recommended checking a tryptase level for patients with systemic reactions to insect stings. Again, because that subclinical mastocytosis issue, which is suggested by an elevated baseline tryptase, and that would increase your likelihood of having a future systemic reaction. So I think he was advocating checking tryptases on patients who have these reactions with insect stings. Not necessarily for locals, but for systemic reactions. Okay, so
Well, what about beta blockers and ACE inhibitors? Was there any information about that?
in terms of like being on immunotherapy?
Yeah, and being stung. I mean, does it change the risk of reacting, or?
I didn't see anything that talked about, you can correct me if I'm wrong, I didn't see anything about increasing the risk of reaction, but it seemed, I think it would affect the degree of reaction. If you're having beta blockade and you're treating someone with epi, you might not get a good response from it, or you might have more hypotension or something like that. So I would think it would be set you up for a more severe if you're going to have a systemic reaction.
Yeah, there's always this debate that comes up. If they're on a beta blocker, it doesn't seem to increase the risk of a reaction, but if they react, you can respond to the epinephrine. Now, actually, it's unlikely you'll get a complete beta blockade, so the epinephrine probably will still work. It may not be as effective as if they weren't on a beta blocker, but it's still worth giving them an epinephrine for a reaction, even if they're taking a beta blocker, as the first drug before moving on to the alternative. And do you know what the alternative is if you're having a systemic reaction and absolutely getting no response to epi? What's glucagon? Okay.
And what about
That's a board question. What?
What about with the ACE inhibitor?
The ACE inhibitor is different, and it's still debatable, but there's some suspicion that it may actually increase the likelihood that you'll have a more severe reaction when you are stung. So not only does it doesn't prevent you from reacting to the epinephrine, but it may increase the likelihood of having a systemic reaction. And so as a result, somebody who's at risk of having an insect sting or has had a systemic reaction, who's getting venom immunotherapy, it may be worth considering switching them to an ACE receptor blocker rather than an ACE inhibitor, because there's no increased risk with the receptor blockers. Very interesting.
Okay, so just to finish up with the post-test here, so question 1 was allergy testing for Hymenoptera is recommended for all the following except I said B, a 7-year-old boy experiences total body hives alone following sting. Remember, the cutaneous only for children less than 16. You don't need to pursue that. That's considered, that's not considered increased risk for systemic. All of the other ones would be increased risk for systemic. True statement regarding venom immunotherapy, like we talked about, it may continue during pregnancy. Basically what I was getting at with the other answers was that rush is as safe as traditional schedules, and pre-treatment's not required to start rush like we talked about. You can start at the day you do the skin testing if you want. And it's not allowable to mix any of the 5 Hymenoptera venoms because of the issue of enzymes breaking down the allergen components of the other. So you can mix the 3 vespids, but you don't want to be mixing all 5 like the wasp. You wouldn't want to mix the wasp with the 3 vespids.
So if you're allergic to, you're positive to bee, wasp, and yellow jacket, you'd have to get 3 shots.
Yeah. And you can mix them into the syringe right before injection. I mean, I've done that. Yeah.
Okay. I guess I meant vial.
If you don't want to actually penetrate their skin 3 times, if it's a little kid, for example. But you don't want to store them mixed together.
Okay.
They got stung with like a hornet, but they tested positive to honey, all 3. You include all 3.
Yes.
And
You don't know if they really were stung by a hornet.
That's right.
And because they're cross-reactors.
Right.
And a trick, by the way, if when you get the vial, you mix it so that it gives you a half a cc will give you 100 micrograms of antigen. And what you can do is add half as much diluent so that it's twice as concentrated, and that way only 0.25 cc's will have 100 micrograms instead of 0.5, and that makes it more likely that you'll be able to combine a couple of them together into one syringe. So that's one trick you can use if you're running into an issue of too much volume, especially for little kids who have little teeny arms that don't tolerate such large volumes.
So do you typically draw them up into one syringe, or do you keep them separate?
I mean, if they're getting 5 different injections, you got to get 2. But ideally, if they're only getting 2 or maybe 3, it's nice to do it in one injection. So I try to draw it up in one syringe.
Okay, and then lastly, the true statement regarding Hymenoptera is so wasps don't usually, they're the least likely to eviscerate themselves. The killer bees don't have more potent venom. They sting more. And it's not acceptable to use whole body extracts for pesticides. We have the concentrated venom, and it is acceptable to use whole body extracts for fire ant testing for immunotherapy.
So I thought you could go up to 200 micrograms instead of 150.
You can, and apparently, if you the way you would know that the injection's not working is if somebody gets stung while they're taking venom immunotherapy and they have a systemic reaction anyway, then it may be necessary to try increasing it to 200 micrograms. The IgG4s and the specific IgEs and all that stuff just aren't very effective for monitoring the effectiveness.
How do you increase it? Just give 200 the next time, or do you build up or anything like that?
You can just increase it.
Okay. And then for the mixed method, it's going to be 600. Right.
That's it. Looks like Brock's got his hand up. Go ahead, Brock.
Yeah, Jay, I listened to a lot of interest, and I think this is another area where the components are really going to straighten a lot of things out.
I was going to ask you, what's the story with venom component testing, and also what about just specific IgE measurements to venoms? How good are they?
They're not that good, only at high levels, because that assures that you're probably picking up relevant allergens. The problem is cross-reactivity, and for example, the group 5 allergens from most of the insects and ants cross-react with Bermuda grass pollen, mugwort, muskmelon. They're called PR1 proteins, and they're calcium channel blockers. And then the hyaluronidase, the activity of that is usually to end-link glycans, which are the cross-reacting carbohydrate determinants, which we find in a lot of different sources, that foods or whatever that have peroxidases or other end-linked glycans. A recent paper's coming out. I think it's already out. I don't know. I know it's approved for Jackie on the use of a recombinant APA1 for distinguishing wasp from honeybee. And they found out, it's very clear, this is Valenta's group in Austria, and it was very clear if they used a recombinant expressed protein from E. coli, it didn't work very well. And if they put it in a system where it was glycosylated, it worked great. But the allergens, the epitopes were not glycans. It was probably folding of the phospholipase. But it's very good if you use that. Well, the current immunocap for recombinant expressed is the E. coli one, and so it doesn't work very well. And they'll probably
change it.
Pardon?
You think they'll change it?
Oh yeah, they'll change it very quickly. The other question I had is if the prediction of systemic reactions by a positive skin test doesn't work after immunotherapy, but does before, are you sure we're not just fooling ourselves and using and saying, well, people don't always have systemic reactions? I mean, is it 100% every time, and that sort of thing? So I'm kind of bothered by some of those the statements, because I don't think we really know that.
I don't think that there's anything reliable that you can use to predict who's likely to do well after you discontinue the venom immunotherapy. And Dave Golden, when I spoke with him, and there's an interview that will be posted on the college's website shortly with Dave Golden, where he'll be talking about these issues, so you'll be able to listen to that. But he said that neither of these tests, the IgE test, the G4 test, the skin test, don't waste your money, don't waste your time, because you're not going to be able to predict who will do well when you discontinue the immunotherapy or not. But you're right. Why is it that the IgE is so predictive before you started it, but afterwards it doesn't really tell you how well it worked? I don't understand that either.
Yeah, I don't understand.
But that's true for aeroallergens too.
Yeah. One other thing is, has anyone ever done any follow-up on immunotherapy to look for novel sensitizations? I mean, because these things do cross-react, like the Bermuda grass with the Group 5 things, and you might predict that you might see a higher incidence of mugwort or grass allergy.
I just kind of wonder if people with grass allergy are more likely to react to stinging insects because of that.
Yeah, I mean that's certainly a possibility because it creates any allergen that gets into the system that you have IgE against creates IgE or it creates a milieu for making IgE to bystander allergens, and also targets that specific allergen to make more IgE to all its epitopes. So, yeah.
Now that we have the component testing, we'll be able to start teasing that apart.
Yeah, I think so. I mean, especially like the cross-reacting carbohydrate determinants, that's on there, and things like that. So, yeah. So.
Very interesting. Any other comments or questions from the group? Did you want to add anything else, Dr. Serota? Anybody else have any comments, questions? All right. Well, thank you so much for this overview of stinging insect sensitivity. And we'll stay tuned. There's more information. For more information about stinging insect hypersensitivity, check out the practice parameter on stinging insect that was recently published in the Journal of Allergy, April 2011. Chief editor is Dave Golden, and it's published by the work group on stinging insects as well as the Joint Task Force on allergy practice parameters. We're going to take about a 2-minute break, and then we'll get back together, and Dr. Delling will describe nasal provocation challenges. This is Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.